All right, committee member Sellers, can you hear us okay?
Yes, I can.
Super. Smee, Emily, are you able to ping your colleague or text them and let them know to join the call? I don't see them on the call.
Yep. She is in a meeting, I know, till 11. She thought it might run a little bit late. Her door's still shut when I just went to chat with her. So she'll pop on when she can.
Okay.
I think probably the meat of what she can offer is a little bit later on.
Okay, if somebody could just let me know when she joins the call because I can't see it, I'll have to unmute her.
Okay.
So I think Executive Director Runyon would like to amend something else, and I'm going to okay, I'm going to go back to this and just a second. So question 13, I highlighted in yellow. We just wanted to make sure that this is where the committee landed on that after we had that discussion. Does that look appropriate to everyone?
So you removed.
Yeah, we removed fever and chills because I thought that's what Dr. Virgin stated, but if not, I can throw it back in.
This is Dr. Virgin. It was not my intent to remove the fever or chills.
Okay.
Yeah.
I'm just gonna, I don't know if it matters where it goes.
Or having fever or chills.
Better?
Due to an illness that you think may not be related to a trauma. Are you feeling? Yeah.
All right, committee members? Better, worse?
Or
Committee member Gibler?
Approve.
You're our go-to.
Sorry.
Okay, so
sometimes I feel I should apologize for that, sir.
But no, it's plain language and it follows our standard for other accessibility reasons for documents. Oh, give me just a moment. Looks like committee member Sellers is having tech problems. No? Can you hear us okay? Okay.
Yeah.
Okay.
All right, should we move on to the next section?
Executive Director Runyon, let's do it.
Okay.
Okay, nothing too sensational here of medication history. This is the same in the continuation pathway as well, and we've listed the note there. We asked this because some common medicines or supplements can change how your treatment works, and we want to make sure everything you're taking works well together to keep you safe and feeling your best. Any comments on that from the committee?
Yeah, this committee member Gibler, just I know you said no suggestions or too minor, so please don't capitalize over the counter.
Yeah, thank you. That's universal.
Committee member Sellers, I I support the sentiment of the note. I also wonder if feeling your best is not the thing to like tell patients that are going through Suboxone induction, because it's going to be a rough road. I would almost prefer it just end it to keep you safe, you know. Does anybody have any objection to that?
Or just finish works well together, period.
Sure.
Well, we're not going to make any promises here.
Yeah, we want to make sure everything works well together. Yes, that's a good point, Committee Member Gibler.
Right, so we've heard from two. The other committee members, strong feelings on that strike?
This is Committee Member Anderson. I'm good with that.
All right, Executive Director Runyon. We'll move on to Section 4, the SOWS assessment.
Hey, Executive Director Runyon. This may be a good opportunity for the SMEs, if they feel it's necessary, to explain this one a little bit. We replaced the cows with the sows, so a more clinical approach which relies on kind of a more tangible or rigid patient assessment that again, some elements of may be outside the scope of the pharmacist practice, especially in the community setting, and replace it with this, which the patient actually fills out, as opposed to something that's administered by the pharmacist. I'm just going to strike one thing here. You'll notice that all of this is in yellow. I copied and pasted something from another document, and then I think I left a note saying I'll just create a new one, a new table, which is what I did here. So I'm just going to amend this to say in the columns below, can you add an S for me? In the columns below, just strike through that. So in the columns below, use the scale to write in a number from 0 to 4 about how you feel about each symptom right now, and have the scale there on the right. So aside from reformatting to a single scale without the date and time, that's all I did here. Any questions from the committee on that, or comments from the SMEs about what this tool is, how you use it, what the utility is, etc.?
Committee Member Gibler.
Yeah, if the SMEs want to comment ahead, I just have a question or comment on the wording. I feel like if you need to define what something is in parentheses, you probably shouldn't have the word that you're using. So just say I'm sweating, I have skin bumps, and I feel sick to my stomach. Would be more easy. It'd be easier to understand, and it would be just clean up the table. And if there's any way to enlarge that, I don't know, for the visually impaired or people that are having a hard time. It feels like it's a little tight, but maybe it's not. It'll be printed out on a piece of paper. I don't know if it should be a standalone on one page, but anything to make it easy to kind of differentiate between the 18 questions and accurately score for people that are maybe withdrawing and not feeling good, maybe not seeing, maybe they have visual impairment. Things to consider.
Committee Member Virgin.
Yes, this is the committee member Virgin. I would agree with the sweating and the sick to my stomach. The skin bumps, that could be a rash. So I might want to keep that one, since, although I don't know if there's another word other than goose flesh.
Yeah, I've never heard the term goose flesh, so that's why I made a
I
comment
have,
on that.
yeah.
But I'm from
I've always used goosebumps, so I'm like, I'm combining it.
Goosebumps. I understand what that means.
So Executive Director Runyon, do we want to change to goosebumps? Emily, do you have any thoughts on that?
I think that's very reasonable to do.
I know none of us have probably defeathered a goose before, but I think we know what that means.
Judge for yourself, though.
Yeah.
Get rid of skin bumps,
Okay, I've
yeah.
defeathered a chicken, but it was a long time ago.
Committee member Virgin, one other question. Are these questions validated in a way that it decreases the validation if we change the language? Does one of our SMEs know that?
You know, it's very funny. This is a little bit of a soapbox, but the cows is validated in a way that we don't actually really use it. So I don't actually think that there's a great scale right now out there, especially because all of these were developed in the setting of heroin or prescription use and not with fentanyl at all. And so we really have tried to step back from the cows clinically and really rely on objective opiate withdrawal. Institutions, pharmacists, I think objective data is really hard to get away from. And so I don't think that there's any validation to the terminology here. So if we wanted to change it, I think that is not going to take away from these, poor scales at baseline.
I'm sorry, did the committee say that we probably need to make that table a little larger? Do
Well,
you like me to
that
do
was
that
my
formatting?
comment. If we can just add more space between the rows, that would just make it easier for people to read.
Okay. I'll look at some of our other protocols and make it sort of universal. Thank you.
Executive Director Runyon, we will continue. And the good news is a lot of these between the two protocol pathways, whether in initiation or continuation of therapy, there's a lot of overlap. So hopefully that'll open up a little time for more robust discussion about potentially some of the more contentious topics. So here we have the harm reduction tools. And we also ask in question 16 about some complementary or more holistic alternative treatment pathways or longitudinal care, if you will. And the only thing I changed, I've left an internal note only, and I struck that a little further down on question 16. As mentioned, I think this will take a little time to put together, as we don't want the pharmacist amidst, having to fill out what's going to be a new protocol experience for them, to then have to do all of this research to determine where these therapies and other alternative complementary therapies might be available in their area. I know Emily had mentioned she may have gotten the ball rolling already, putting some feelers out there about how we might corral other members in the community and the platforms that we have to create some sort of regional resources for our pharmacists that haven't used, so that burden is not placed on them. But all of that to say, section 5 is the same between both protocol, and I'll open it up to any questions from the committee on that.
This committee member Sellers, I think that this is great. I do think that we'll need probably some support for our pharmacists in the community that are using this protocol in terms of getting those materials together, but this looks wonderful. Thank you.
This is Committee Member Gibler. I appreciate this as well. I don't know, when you're asking the patient questions about the test strips and the lethal additives, that they're not always lethal if they've they can be lethal, of course, but I just don't know if that's a confusing way to ask the question using the term lethal additives. But you might, if they want information on test strips that check for fentanyl and xylazine, that might, I don't know, because everything off the street has fentanyl in it now. So I've heard that people make the assumption that there is fentanyl already. I don't know, maybe I'm overthinking it. I just want to make sure it's not something they're like, yeah, I don't want, that they will say no to when it might be something they might be interested in. Call it, but.
Executive Director Runyon, what about using the word harmful? Might be a little more accessible, still get that, point
Harmful,
across.
like harmful chemicals or harmful contaminant or harmful contaminant's not an easy word either, but
What about potentially lethal?
I was trying to remove lethal, the word lethal, just because it's a loaded term.
This is committee
Harmful
member Virgin.
chemicals. Sorry, go ahead.
Committee member Virgin, while I agree with the desire to decrease the stigma, there is a part of me that feels that lethal is one of the key things, since we're seeing so many deaths across the nation related to fentanyl. Xylazine, I'm less familiar with. I do like the language of potentially lethal, but I could go with harmful. Just my thought.
This is committee
Yeah.
member Sellers. Can we just get rid of both of them and say check for additives in the drug supply? Or do you think that's not descriptive enough? I'm just wondering.
Well, I
if,
don't think
like,
that's descriptive enough, but
Okay.
I'm fine just
Okay.
leaving it as lethal additives. That's fine. I part of the reason I said that is I had the thought and I didn't know if I was the only one thinking that, but often I overthink things. So
Did the committee
That's it.
agree on potentially? Do we want to leave potentially in this or take that back out?
Did the committee agree on adding potentially in there?
yeah, that makes sense to me.
Yeah,
I
as
like
committee
that.
member Sellers, that makes sense to me.
Yeah, this is committee member Anderson. I agree.
Okay, Executive Director Running, we'll move on from section 5. I talked about it.
Okay.
So then we just have the patient attestation left. No changes on that from the initial submission to the committee. And then we have the pharmacist verification of community therapy. This is the same between both pathways. This is the core, these are the core elements of the PDMP data. If they pull that and haven't to find anything. Open to the criteria here, addition or subtraction, amendment of any of the fields, wording, etc. And then we'll just wrap all of this up. We have the pharmacist signature on the bottom. And the only reason section 8 is highlighted is because I added one section in between and just had to renumber it. So we'll just open it up for any comments from the committee on section 6, 7, 8. So patient attestation, the PDMP check, and then pharmacist signature.
Committee member Gibler.
Just question 1. Pharmacists are the medication experts, so I don't think we need to list examples. Just say medication and formulation and then dose. And then, yeah, unless others feel like a pharmacist will need to be reminded of that.
Committee member Sellers agrees and certainly hopes that they don't have to be. Committee member Wickenhagen.
Looked at the previous version and I was kind of concerned about, checking the PDMP. Again, pharmacists have that at their fingertips, I'm assuming. But no need to necessarily attest to that. I know like advanced practice nurses are required every time we prescribe anything that's a controlled substance. Maybe that's just an obstacle for us, but I don't know what the status of that is for pharmacists.
Executive Director Runyon, I think the difference here is pharmacists are typically used to doing that as part of the prescription process when they're dispensing medications. But the standpoint of doing that is a little different when you're actually prescribing. So we felt it necessary to include that on the front end to evaluate whether or not the patient should be prescribed something to begin with, kind of in line with what other providers do. But I appreciate the feedback, and of course open that up. We would like to hear from other committee members. And we'll also take out everything from medication forward. So we'll just leave medication and then dose, and then strike through the rest of it. I'll open it back up for a comment.
As committee member Virgin, I would agree. I can't remember if it's required. I know within my former system, it was required. It was a hard stop if you didn't check the PDMP. But I agree with the recommendation that all of the rest of it is unnecessary and duplicative.
Committee member Gibler, what's the difference between date of last fill and last sold date? What's the last sold date?
Executive Director Runyon, if I'm not mistaken, that is a differentiation that's offered on the PDMP report. So let's say a patient has something filled, say they get their oxycodone on January 15th, but they can't make it to pick it up until, the weekend or the following Monday, so that it's not sold until the 20th. So that might help to determine what could potentially represent a clinically significant gap in therapy, but is not. Let's say if you looked and didn't differentiate between those two, you would say, oh, the patient got this on December 10th, and now it's January 15th. Where did those extra 6 days go?
No, that makes complete sense. I guess I didn't know what last sold date versus date dispense. I think they're the same thing, it sounds like.
Correct. Yeah. And we can reword that, or date sold might be.
Well, if they have no copay, they didn't sell anything. If they're on Medicaid, there's no sold date.
Okay. Any other questions on this document before I close it and we move to the next? Member Sellers, does that sound okay?
Yeah, so committee member Sellers, I know that we had questions about the question 7 mental health component. Are we, do we want to revisit that? I think we have to use that in conjunction with the other document you had pulled up previously.
7, 8, 9.
Oh, 7, 8, 9.
Yeah.
Do we have that? Do we need comments stuff? Okay.
Executive Director Runyon. So we'll keep this minimized so we can easily toggle back to it and reference as prompted by the treatment care pathway. And I think that's number 5 on that.
Okay. So we're going to start this, right? Because we haven't done the top.
Okay. Executive Director Runyon will move on to document 3. First question is, and I've included this on both, and it's kind of an overview, not necessarily a checklist up top, and we've indicated it's not to be used in lieu of the full screening tool below. Does the committee see value in leaving this eligibility criteria summary up top?
Committee member Gibler, I don't recall us usually having this part in our protocols, but is this something we usually do?
Executive Director Runyon, I don't think we've done that previously.
I love consistency between our protocols just for ease of use for the end user, but so I would be fine just deleting this. It doesn't appear, I feel like these are checked off anyway. I don't know if pharmacists would actually use this checklist.
Committee member Sellers agrees with committee member Gibler.
We need 2 more for consensus on this.
Executive Director, and we just need 2 more.
Community member Virgin agrees. We can strike this.
This committee member.
Committee member
Anderson.
Hammond, I agree. Oops, sorry.
I was going to say the same thing. I mean, it looks like all of those things are found below anyway. So yeah, I'm in agreement with removing it.
Okay, we'll continue on. Question 1 relates to the demographic info. It's patient 18 years of age or older. No change there. Number 2 asks about medication allergies, as annoying as that can seem sometimes. Committee member Gibbler, you have your hand up.
Yes, I apologize, but I just want to get a broad comment about this document that it's a little distracting with all the colors and the bold. Like when I read number 1, I don't even necessarily see at first that the question is actually as a patient 18 years of age or older. So I'm just going to make a general comment about all of these questions, that we're careful what we're bolding and what we're highlighting and what our font size is and the colors of yes and no, as it can be very distracting and sometimes even difficult to read if you print it out.
Executive Director Ryan, yeah. I agree with that. What we plan to do, because this red and green thing doesn't pass the accessibility standards in any way, is we would, if the committee feels it's appropriate, any no answer, we could just use like a light gray if we wanted to shade them at all, and the other one would be white.
Committee member Sellers, that sounds good.
I agree, thank you.
And then unbold everything, or do you want the question bolded? You want to reverse?
Executive Director Running, again, I have no predilection either way. I'm not attached to any presentation of this. So I think the question from staff member Melvin was, did we want to do anything about the bolding, either of the question itself, removing that, or removing the bolding and the decision pathway, either yes or no?
This is committee member Virgin. I would recommend unbolding the header and bolding the question.
And then I would just add, whatever we do with the other protocols, do with this one. This one just looks different to me than our other protocols, the way it's laid out. And so I don't care what it just needs some, I don't know where the changes need to happen, but I think something to do with the bolding and the layout and the coloring would be very helpful, so it aligns with our other protocols.
Very good. Staff member Melvin, I will clean these up before we present them to the board, and I will do my best to make them universal towards our, so they match our other protocols. Thank you.
Okay, so I think we can move on to question 3. That's about opioid use history. And this is just obviously a pivotal requirement of therapy, and we asked about that in question 1. And so obviously they would need to indicate that they have or believe they might have OUD for those questions. No changes there. Section 4, I mentioned those changes earlier. In the patient intake form, just combining, I think, was questions 5 and 6 into 1. And then I think there was a typo in the decision tree there, so I fixed that and referred to another provider due to potential contraindication, or we can reword that if the committee sees fit. Any questions up to this point? Okay, seeing none, we'll continue. And I think this is the point where we had some questions that we want to toggle back to the patient intake form. I think it's questions 7 through 10 about the suicide risk and then the acute crisis or process, if you will. And back to that. So this just says, does the patient report current suicidal ideation? And then we'll go back to questions 7 through 9 there.
Hearing problem. Sorry, I have to do that every time.
Okay, and here are the corresponding questions on patient intake form. I'll open it back up for comment here.
This is committee member Sellers. Is question 8 relevant? Because we're talking about their current mental status, correct?
Executive Director running. I may refer to the SMEs on that.
This is committee member Virgin, not a SME, but I do think it's important to ask about prior attempts. It, I think, goes to, risk should the individual be experiencing additional, depression or other symptoms. I would recommend leaving it.
Oh, I see. And in the corresponding document, there is the non-immediate threat of kind of getting them connected with other. Okay. Okay.
And so, this is committee member Gibler. So, you recommend keeping it because, I suppose, because maybe more recent history. So we have a date and time we're recording this, but if they're 36 and they had an event when they were 17 or 18, probably wouldn't be relevant right at this point, would it?
Committee member
So
Sellers, yeah, that's what I would think. The problem is that when you go over to the treatment care pathway that we were just reviewing, all of them fall under the yes, do not prescribe. So if there's any history, it would not allow the pharmacist to prescribe. So that's my concern.
Yeah, that's my concern then, is
yeah,
that we have people that have a resolved past medical history that makes them ineligible for something that they should be eligible for if it's in the distant past.
7, 10.
Yeah.
Committee member Virgin, could we go back up to I think question 8 on that other document? Because again, I feel strongly that we should limit barriers to treatment, and I guess I missed that. I agree that the history piece is important, but it shouldn't preclude a patient from being treated.
and I think that's my point, though, is that it's like, if it's because this is a relative, these inherently don't allow for a lot of judgment, right, from the pharmacist. And so if there's a question that's going to either cause confusion or restrict access, I think we have to be really thoughtful about that, since we're not allowed to make those kinds of judgments, right? So do we need this question? Because we have no guidance for them.
Yeah.
If the answer is yes, other than they cannot get buprenorphine. And to committee member Gibler's point, if it happened, 5, 10, 20 years ago, potentially.
This is Smee Stringfield. I agree with that statement. And I think just as an overall just takeaway is the more questions you are forced to check off a box on, the more likelihood that you are going to come up with a barrier to care. So yeah, in reference to this question, I mean, it's excellent as far as, if you are being required to pass on information, you want to gather this, but take into consideration it could lead to you not being able to technically prescribe the buprenorphine down the road.
Executive Director, and just for clarification, I believe in the treatment care pathway, the only question that we've included in that bifurcation is 9. Whether that kind of weighs either way in your decision, it would only be 9. So a previous history 15 years ago is not included in that evaluation. So it's only question 9 and whether or not they're currently experiencing that. Not that it would change some of the discourse, but certainly those other questions wouldn't prohibit someone from being prescribed the induction regimen. I think that's.
This is committee member Sellers. I can see that. I don't know that that's going to be how it's interpreted by the pharmacists who are utilizing the protocol.
Yeah.
And again, I'm concerned that we're asking questions that if it's not changing our ability to prescribe and is more of a nice to know and can really help with counseling. Again, love the opportunity to get to know patients and have those guided conversations, but I think that this is really confusing.
Yeah, this is Smee Stringfield. So someone who has borderline personality disorder is pretty much chronically suicidal. And so that would just be one example to consider for a patient that you're going to be doing an assessment on. And so, yeah, you can have suicidal thoughts. Doesn't mean you're acting on them or have a plan to act upon them. And so that kind of just does create maybe an unnecessary barrier.
This is Emily. Oh, sorry, Gary.
Oh no, go ahead.
I just wanted to unmute real quick and just say that Dr. Englander is on. If you guys want her to weigh in on any of this, you can give her unmuting capabilities. Is now an okay time to do like a quick?
Yes. Yeah.
I think this is a great time. Yes.
Okay, great. So I just want to introduce Dr. Englander, who's here. She is my personal hero and such a great champion in enacting change all throughout, not just the US, but all across the world. She does a lot of really cool work in France also. But she is here to help weigh in. She's an expert in all MOUD treatment, so she's just here to help weigh in and answer any questions that we may have from addiction care specialists. So she's lovely, and I'm so glad that she's able to be a part of this.
Thank you, Emily. That may be the kindest introduction ever. I'm not sure I'm deserving, but it's really an honor to be here with all of you. Emily has shared just the really pioneering work that you're doing. I am such a huge, I just think that having pharmacists as part of our interprofessional team, having Emily as part of our interprofessional team has been transformative. And I think the role of pharmacists in this space just represents so much untapped potential, and I'm delighted and honored to be here.
Thank you for joining us, Dr. Englander. This is committee member Sellers. So we are right now going through we're still in the initiation of care protocol, so the induction protocol, and we've approved most of it and, with some edits, but we're stuck on the section for mental health. And just to kind of summarize some of the concerns with this, the only question out of questions 7 through 10 that could actually potentially cause the pharmacist to not prescribe it is question 9, which is sort of immediate suicide risk. There's a couple other points. So question 1 is, do we need this section if it's not going to result in a different decision, prescribing decision by the pharmacist? Point 2, one of the SMEs brought up that there's some folks that are sort of chronically suicidal or passively suicidal or something, and should they be have restricted access? Did I summarize that well? Please jump in and give any additions or corrections, committee.
Yeah, this committee member, I think in addition to that, someone with something like borderline personality disorder that has chronic thoughts of suicide, whether they ever follow through on that, is that complex enough patient that we really should be referring those patients to receive maybe better care than what a pharmacist in this setting could provide in the moment.
I can reflect my sort of instinct on it, which is I probably would leave this section out. I think that but again, I know I'm obviously sort of just coming in with limited context for the conversation, et cetera, but if somebody's presenting to a pharmacy looking for buprenorphine, the chances, to me, sort of the chances that they're doing that hoping to complete suicide with buprenorphine is next to none. It's just not a good way to complete. Like, I think people know that, and so if the question is sort of, are there additional resources that somebody would need to improve their health? Maybe there's sort of an open-ended catch-all question that can inform a pharmacist's attempt to support a patient, but I don't think specifically asking about suicide risk may be unnecessary. I don't know if that aligns with how the committee is sort of leaning, but that'd be my thought.
Committee member Sellers, I'm leaning in that same direction, but I don't know. I haven't heard extensively from the others yet, so.
Yeah, this is Smee Stringfield. Yeah, in my experience, assessing suicidality is extremely nuanced, and it could easily lead to unnecessary barriers. The picturing how a conversation between an outpatient pharmacist and a patient who's approaching for help with active withdrawal could go, and it could really lead to a lot of denial of buprenorphine. I believe that could possibly be more harmful versus like Dr. Englander said, you really got to try hard to overdose on buprenorphine. It's hard to do, and so the risk giving someone buprenorphine who is potentially chronically suicidal is, I just don't know if there's a connection there with the way this is worded.
I'll just share, even in my role as a physician in the hospital, you know, starting bup and methadone all the time, I do assess sort of mental health needs more generally, and I'm working in a setting where we have lots of staff trained to support folks. But it's not the first thing I do. If I'm seeing somebody in acute withdrawal, or I'm seeing somebody who wants to start medication for OUD, I recognize that those medicines are going to overall make them feel better quickly. And so it's not my top priority. So again, even in a hospital setting, it's not a priority. So I don't think it would need to be in a pharmacy, outpatient pharmacy setting either.
And so if it is removed, then the pharmacist will not be asking about this. And so the question is that okay? We're asking no question about suicidality for patients, regardless of how they're presenting, at least on the protocol.
I think that's appropriate, personally.
Perfect, thank you.
Okay, this is staff member Melvin. So just so I understand this clearly, we are talking about eliminating 7, 8, 9, and 10. Is that correct? Hair sellers?
Yes, that's correct.
Okay, so do we need consensus?
Committee member Virgin, I thought we were talking about 7, 8, and 9 and not 10? Since 10 speaks to acute pain, illness, physical distress.
Well,
Just
this is committee member Sellers. I think the problem with 10 though is that that's not part of the decision tree at all. Okay. So what is the value add? That's the question.
Executive Director Running, it is the question following that. So all of this relates to number 5, or I say question 9 does, and then the next one, question 6, actually does include that in the decision tree. It's question 10. It doesn't have to be included, and we can certainly strike that in tandem, but it is represented as the next step on the treatment care pathway in number 6.
I apologize, I misread that. You're correct. That's,
Let me share that real quick.
Again, we're happy to strike that if the committee deems it appropriate.
The acute pain, one would argue that anyone in acute withdrawal is going to be experiencing distress and acute pain. And so I think that could limit who started. I think you would eliminate a lot of people who are in acute withdrawal with those two descriptors.
This committee member Anderson, I would be in agreement. I think that we're getting at some of these other things, especially with like chronic pain with other areas. So I like the idea of getting rid of this one as well.
Committee member Wickenhagen.
Yeah, committee member Wickenhagen. I think that pharmacists are going to recognize if somebody's in an acute crisis, and immediately they're going to say, you need to be evaluated at a higher level of care. Thank you. Bye-bye. So I don't know that it needs to be in the protocol.
So are you proposing to strike question 10 completely?
I am.
Okay. And committee member Gibler?
Yes, I agree. Thank you.
And I agree as committee member Sellers. Anyone have opinions against? Okay. So we're to review, we are striking questions 7 through 10.
Right. I'm gonna go back to the other document. Okay, got it. Okay. We'll remove section 5 and 6 on this, and now I guess we're here. 7.
Okay. Executive Director, and move to question 7, which referred back to 11 on the intake form, asking about whether the patient is currently being prescribed treatment for chronic pain by another provider. And I think we had agreed earlier that if so, that coordination with that prescribing provider would be necessary in order to continue with the induction pathway here. And I'll open that up to committee discussion.
Smee Stringfield has your hand up.
Oh, I actually was hoping to bring up a different topic but yeah, I'll wait until we address what committee member Runyon just mentioned about chronic pain.
Can we make it more specific for chronic pain with opiates? Someone could use, pregabalin or gabapentin or something else for chronic pain that is not an opiate, that wouldn't preclude them from.
Yeah, committee member Gibler, I agree. We don't need physical therapy to negate treatment.
Committee member Sellers agrees.
All right, that's 2. We need 2 more.
This is committee member Anderson. I agree. I was actually kind of thinking that as we were going over that question in the questionnaire anyway. So.
And committee member Virgin agrees.
Yeah. So do we need to go back and adjust that question in the questionnaire to be specific to, are you being treated for chronic pain with opiates? Because I don't think, am I incorrect in saying that it doesn't say that?
I think
This
you are
staff
correct.
member Melvin, I amended it earlier. So right now it says, are you currently being prescribed medication for a chronic pain condition? Opioid medication is what they're proposing. Yeah, so it doesn't say that now. So correct. Yes. So we want to add opioid. Let me share this again.
We're switching screens so we can amend that in the intake form.
I almost wonder, should it include information about a pain contract also? And also maybe, have you been prescribed an opioid for a pain management condition under contract within the last 3 to 6 months, 3 months possibly?
This is committee member Anderson. I'm not sure that that would matter, given that in the treatment pathway, there is a stop regardless, and saying, working with the provider anyway. So I think if the pharmacist has to contact the provider that's prescribing opiates for chronic pain, then they'll theoretically learn that information.
And for people.
Wait, what do you, oh wait, which prefer? This is Staff Member Melvin. So does the committee, would you like this to be phrased how I have it right now, being prescribed opiates or opioid medication? I heard two things.
This committee member Anderson, I would like opioid medications.
I would prefer opioid medications as well. I think that's the language we use more commonly in the literature.
I guess I just do have a little bit concern about the hard stop language, referring to, is patient currently being treated by another provider for chronic pain? If yes, don't prescribe, coordinate with the pain management provider. I think it requires more definition as to what kind of pain management provider they're seeing. And if there's a contract there that states, limits on.
Oh, you're on mute.
It just seems a little bit wide open. I'd like to hear what other members think about that.
Dr. Englander?
Specifically related to the contracts, my concern is that oftentimes patients get placed on contracts kind of as a punitive measure, not as a therapeutic measure. And if somebody's coming in asking for buprenorphine, they're looking for care. So I wouldn't have the existence of a contract be a hard stop for prescribing bupe. I think the sort of co-prescribing for pain medication, I don't know that it needs to be a hard stop. I think it could be a communication touch point, but I don't know that it has to be that the patient doesn't get bupe until the provider is contacted. Though again, I don't know. That would be my preliminary thought there.
Which then brings up the question. I mean, we're going to be contacting the providers regardless, telling them that we're prescribing buprenorphine. So it brings up the question about, like, should this be a yes or no hard stop included?
This committee member Anderson, I agree. I'm kind of wondering, maybe instead of it being hard stop, maybe we could say pausing until that prescriber is contacted and provides input.
Committee member Sellers, I hesitate with that. It's almost impossible to get in touch with somebody within 72 hours.
Yep.
And I think, I worry that you have this really kind of sacred window where these patients are open to it and already there being vulnerable, that I want to take into consideration. Committee member Wickenhagen, you had your hand up.
You took the words right out of my mouth.
Oh, okay.
Thank you.
Executive Director Running, I think the only question I have then is about precipitated withdrawal. If we're not coordinating care with that pain management provider, what is the likelihood that they may be taking something that without proper coordination, and we start bupe, and if indicated by the SOs, which we've heard we don't really like, is that score in and of itself good enough to, regardless of what the patient answers to this, to assure us that we won't induce a state of precipitated withdrawal because they are on and are currently taking other opioid medications that might cause that when bupe is added, if that makes sense.
Certainly the timing of it. So one of the questions is, when did you take your last dose? And that, I think, is an important piece of information to take into consideration when telling the patient to start buprenorphine if they're on prescription opiates, but it's usually less than, like the duration is less than that with illicit fentanyl use.
And Smee Stringfield.
Yeah. Hey, and so I guess backing up a tiny bit, I'm assuming that before a pharmacist is going to be able to engage in collaborative prescribing of buprenorphine, that there's going to be some sort of requirement for a training, which is going to hopefully help take care of a lot of the, needs for, like, relying on the pharmacist to make some of these clinical decisions. One other point of clarification that I was hoping to make, maybe this is my own fault, but I was under the impression that we'd have the option of doing a buprenorphine start outside of just a standard protocol. Is the low dose induction or low dose start going to be an option?
Executive Director Runyon, there is a one size fits all, if you will, quantity restricted induction protocol at the very end. I think it's possibly at the end of this document at the very bottom.
Mm-hmm.
If the patient meets all of the criteria.
Yeah. I'm assuming if we make the training appropriate to where the pharmacists are able to recognize the need to pivot to a low dose start option, this would really help with navigating some of these questions about potentially precipitating withdrawal versus having to heavily rely upon some of the criteria for doing a standard induction.
Executive Director Runyon. So just playing devil's advocate here, just to make sure that we're directing pharmacists to make the right decision, because in the confines of the protocol, it has to be one or the other. And there's no, unfortunately, because of the statutory restrictions, there is no room for them to decide, within this range, I can do A, B, and C, and I'm going to choose C, unfortunately, until the statutes are changed. So what if the patient says, yes, I am currently taking oxycodone 80 milligram or Oxycontin 80 milligram twice a day, and I took my last dose this morning? What would we do then in moving through this particular question, and how would that change the bifurcation, or whether or not we continue with therapy? Because I'm not sure if it leads to us not initiating therapy or induction because of the concern for precipitated withdrawal, then I think we have an obligation to in some manner spell that out for the pharmacist, because we, as is, we're not doing that.
So
yeah, go ahead.
Sorry, committee member Sellers. So the way that the prescription that the pharmacist is supposed to use is, the first thing that it says is start when you are in moderate withdrawal, right? So I mean, is that not accurate? Like, do we need question 11 if we're already telling them that they have to be in withdrawal when they start?
Executive Director, and in that is exactly what I was trying to highlight by asking,
Okay.
Is the SOS enough to ensure that we can avoid precipitated withdrawal regardless of how the patient answers this question, given that there was expressed concern about the clinical accuracy and or utility of it? So I agree with you 100%. That's kind of what I was getting at. Can we rely on that as a clinical tool to ensure that we're not putting the patient in harm's way by potentially starting that sooner than it should be?
And committee member Gibler, your hand's up, but I see the SMEs shaking their heads no, so I want to give them a chance to respond.
Yeah, let's finish this dialogue here.
Okay.
Yeah.
Okay.
Can let Honora speak to it as well, but I don't think that we don't rely very heavily. I mean, we have to do it in the cows because nurses. But I think the patient experience when they feel like they're in moderate withdrawal and listing out 2 objective signs, make sure you have, a list of these things, make sure you're experiencing 2 or 3 of them. That I think is probably more a clinically accurate tool to go off of instead of the cows or the sows. But would love and or Dr. Englander's input too.
Yeah, I mean, it's, I'm trying to sort of envision what this looks like in this setting. To me, it would be useful to know if somebody's taking MS-Contin or OxyContin versus short-acting opioids, just to know what the risk of a precipitated withdrawal would be. But I think generally I ask patients, when do you think, when you're experiencing enough withdrawal, they tend to know when they'll be ready. And so just as Emily says, there's no sort of hard and fast number. And when you look for a hard and fast number, it absolutely depends if you're in Connecticut or Oregon, what the right hard and fast number should be. So
Wow.
there's no, I think it's just tricky. And I would give, I guess the question or my question is the question there to guide pharmacists or to guide patients? I think it's okay to just say moderate to, moderate, at least moderate withdrawal. Most people are ready. Use caution if someone's taking long-acting opioids or illicitly manufactured fentanyl, and consider waiting longer. And so it's sort of just some guardrails around that. But if somebody's in moderate withdrawal and, taking oxycodone, that's easy. Again, that's not most people either, but I think that maybe just a little bit of guidance or parameters. I don't know if that's useful.
Yeah, and I wondered, Dr. Englander, Emily, if maybe a risk score for precipitated withdrawal could potentially be generated from some of these questions that then moves the pharmacist to a point of deciding, okay, you've accumulated this many risk factors for precipitating withdrawal. I'm at a decision point where we're going to go standard versus low dose induction. And then you can document, I feel like the patient's at low risk for precipitated or high risk based off of these accumulated risk factors. And that's why we're choosing one path or the other.
This is committee member Sellers. I love that you're thinking about this and kind of trying to get the exact right thing for folks, even though there's no right answer. My concern is that when we start doing that level of sort of decision tree, what you're going to get is a response from quite a few pharmacists. They're going to say, I don't have time to figure this out. This is too confusing, and it shouldn't be, right? It shouldn't be. But I do think that realistically, it's probably we have to pick an induction regimen and go with it.
Wouldn't the training though maybe help self-select for pharmacists who are going to be engaging in this practice anyways though? If you make the
fear
training,
is that you're going to end up with 0, right?
I
mean, to be completely
the
honest
training
with
is
you.
typically like an 8-hour opioid training if you're going to be a DEA prescriber, right?
Right.
I mean, it's an 8-hour training, I believe. And so
doing the training for physicians does not mean physicians prescribe. I tend to agree that keeping it simple would probably be beneficial. Just sorry if I interrupted there, excuse me.
No, you're fine.
We just have so much data that shows that even when folks were doing the waiver trainings, they weren't prescribing. So I sort of worry about that. I think it would be fine to stick with a traditional induction and just say, advise patients to consider waiting longer if they're taking long-acting opioids or if they have a high fear for precipitated withdrawal, but keeping it pretty simple. I wish we don't have good risk scores to predict who might have a precipitated withdrawal. And that really is where the shared decision-making comes in. I saw a young kid in the ED not that long ago who he was pushing for it. He wanted bupe. I was a little worried he might precipitate. He did. He was okay with it because he wanted the bupe. That's when he wanted it. And so, again, I think it really is about that shared decision-making and ultimately giving some parameters of when to potentially wait longer. But I don't know that it's on the pharmacist. It's just so hard to predict.
Executive Director
Sellers.
Runyon.
Sorry, go ahead, Executive Director Runyon.
So to satisfy the requirements of the protocol for the pharmacist to be able to utilize it, could we craft something that would say, okay, if the patient has taken, or to the patient, wait at least 3 days after taking a long-acting opioid like MS-Cotton or Oxycontin, wait at least, or wait at least 5 days after taking that, wait at least 3 days after taking an immediate release product. And we could somehow include that in the auxiliary instructions for the induction protocol so that it's not prohibitive in the confines of this question, but the patient does have the information that they need to be able to use it kind of responsibly in a way that minimizes side effects. We just need something to be able to let the pharmacist know, yes, you can continue, and perhaps something for the patient that we can include in those auxiliary instructions that lets them know how to use it responsibly. We just have to eliminate the judgment piece for the pharmacist.
Committee member Sellers, I'm just concerned that I want to provide access. I agree we need some guidance for some of this, but none of this is ever going to be completely risk-free and rosy for these folks that are choosing to go through this process. So I think I guess my question is, can we strike question 11 since we're already asking them about medications in other sections? And can we get rid of that? Is that, I could be hearing what you guys are all saying completely incorrectly, so jump in, but is that going to change anything? Because how it's prescribed, if you go down to the induction regimen, it specifically says once you're in moderate withdrawal. So there has to be a conversation about what that looks like. And a lot of these patients, it's been pointed out, tend to know what their withdrawal symptoms are. And
scroll down into what she's talking about.
who wants to jump in? Anybody, please.
I'm going to go back to my original question from like 15 minutes ago. And I just want to step back. This is a universal protocol for every pharmacist that completes the little limited training to perform this care. And I agree this care is needed, but we're talking every pharmacist that completes this. And every practitioner that is prescribing chronic pain, we're assuming, now I appreciate how progressive everyone here is, and your expertise, you work in these areas all the time. I'm just not sure if we have a pharmacist in the grant prescribing buprenorphine, that the PCP that's prescribing oxycodone for the patient doesn't need to know before it's prescribed, and that some level of collaboration or coordination takes place in these settings. And I'm not saying that because I want to limit who's prescribing. I just feel like if someone's being prescribed chronic opioids for chronic pain, that before, like, we need to make something that's universal, that applies easily for every pharmacist and every caring provider who's also caring for the same patient, that works for everyone. I'm concerned that there's going to be a lot of angry physicians that may be filing complaints with the Board of Pharmacy because nobody collaborated with them on their patient. And I understand this is now in statute, so there's some protection there, but I want something that's very comfortable for every pharmacist to do. And so I don't see, like, I understand everyone's point, but it would almost be nice to have just like mid-level practitioners, what would be the standard of care for mid-level practitioners right now if they receive this type of patient that needs help for opioid use disorder? Do we are they right now, would they call the primary care provider that's caring for the patient or before treating, or would they go ahead and treat and then let the provider know what they did? And I just need something that's easy and works for everyone for this protocol to be successful at all.
Committee member Virgin, trying to answer your question, as a PCP and also as a leader within an organization that helps to, guide these conversations. To answer, I think your specific question about what and our language is APC, advanced practice clinician, would do, a PA or nurse practitioner. They often, when they are treating a patient in concert with a PCP, there is a certain level of discomfort in starting this unless they're working within a specific clinic that it treats patients for addiction or chronic pain. And I would say that they would probably feel like they do need to communicate or connect with the PCP, so at least they are aware of what's going on. I think based on the level of comfort around prescribing with that prescriber, either starting and communicating is reasonable. But I would say most would probably, defer and refer. Just my.
So, yeah, committee member Sellers, and that is a good point. I think the big concern though is that if you are an advanced nurse practitioner, the doctors take your call. They don't take pharmacist calls, right? Like that's, it's just concerning that, and maybe they don't take your calls either. I don't know, but again, we're in this kind of sacred space window where it's like, in order to come and ask for something like this in a community setting, you're probably ready to start now. And I do think that delaying care by at least here in Portland is like a minimum of 72 hours. You're just going to end up flooding your emergency rooms and doing this there, which, and again, maybe they'll take the calls from the ER physicians and not the pharmacist. I don't know, but I'm trying to think of like what is the worst that's going to happen? And if physicians get upset and the law gets changed or they complain to the board, do we care? And I mean that just, like what's the worst that's going to happen? I'll let other folks speak. It looks like committee member Virgin and then Dr. Englander.
Yes, committee member Virgin. I would much rather get a notice from a pharmacist. Again, I think there will be some physicians may not be familiar, with this new statute. However, knowing that it is our collective goal to improve the well-being of our patients, I would much rather have a physician or have a pharmacist initiate and let me know than not have my patient be treated at all. I have over the years been surprised with patients that I did not know had opiate use disorders, especially those that were using, unprescribed medication. And so I want us to find a way to make this work.
Dr. Englander?
I appreciate the discussion. I agree. I think it's fine to sort of inform after the fact. And if I really do, I think it's okay. I think the goal is to expand access. And if someone is in the pharmacy and ready, that should be everyone's priority. So I'm really, I like landing there. Yeah. And it's a little hard for me to, I guess I can understand that somebody might be frustrated but at the same time, because buprenorphine is so much more of an effective intervention and safer, I feel hard pressed to imagine that from a patient-centered lens, there would be too many downsides. It's not like somebody's on bupe and they go into the hospital and the hospital stops their bupe to give them short-acting opioids, which happens all the time and is a big problem. But to me, this is the opposite. This is mitigating risk and meeting patients' needs. And communication can happen in a sort of feasible time frame. I'm gonna have to hop off for a different meeting, if that's okay. I'm sorry to not be able to stay a little bit longer. This is really rich, and if I can help in any way, please count me in.
Thank you
Thank
so
you.
much, Dr. Englander.
Thank you all so much. Really appreciate it. Emily, thanks for inviting me.
All right, let's hear from our SMEs.
Yeah, so piggyback on what Dr. Englander just said, I love that. I love that idea. But if I'm taking into consideration with what committee member Gibler also mentioned as far as maybe the more extreme end of like the conservative approach and not wanting to get these like complaints from, you know, the medical board, should we consider a time frame of last fill that is, you know, recognized in the PDMP for indicating maybe a stepwise process as far as like I can prescribe without reaching out to the physician first, or I need to reach out first based off of how long it's been since that opioid has been prescribed, looking at the PDMP.
Committee member Sellers, I guess my concern is that the PDMP does not give us the relevant information for the question that's being asked, because it's not telling you when they took it, right? Isn't that really the question at hand?
True.
Yeah. Committee member, or sorry, is it SME Skogard? Skogrand, sorry.
Skogrand, yeah, you can call me whatever you want, doesn't matter. I think, you know, and to your point, which I really appreciate you making, is what's the worst that can happen? I think we should be much more scared of overdose and the return to use and illicit fentanyl than we are about buprenorphine, right? Buprenorphine by itself does not kill anyone. Where all of the other opiates do. And so also to keep that in perspective, I do really appreciate, we do have to cater to some of the more conservative parts of this, of you know, the medical community. But I do think that the risk of not offering buprenorphine is, in any like clinical scenario, is so much worse than figuring out, okay, well, they took oxycodone 8 hours ago. No one wants to do harm, but I think it's more harmful to turn people away when they're ready.
Executive Director Runyon, I see your hands up.
Thank you. What I would recommend is realizing there's a distinction between notification and blessing. I think we could easily format this in a way that prompts the pharmacist to notify the last prescriber that was listed in the PDMP, especially if it was recent. But that doesn't mean they, like Dr. Englander was saying, you know, it can be after the fact. So we can require notification, but that doesn't mean that that notification then is a requisite of therapy or continuing throughout the treatment pathway, if that makes sense. But I think it is a good thing to do, but and we could require it or require the attempt, and the pharmacist can document that. But I don't think we need to go so far as to say we have to get their okay with that or our decision before we offer therapy. I think that might be enough of an olive branch to not, pardon my language, piss off all of the physicians, which we don't want to do, while making sure that, we're still, like Emily said, taking care of these patients when they're at their most vulnerable moment. And, risk versus benefits says we need to offer them therapy. And then the other point I have, I did speak to the medical board ED, Nicole Krishnaswamy, have a great relationship with her, and kind of learning from past misadventures over the last couple of years that I've seen various bills fall victim to. I think it might be a good idea. Well, she's offered to meet with me and her medical director to discuss any concerns I might have depending on what may come out of this, understanding that, yeah, we want to be seen as part of the holistic care continuum, not just pharmacists are on our own and, you know, physicians be damned and we're just going to do whatever we want. I don't think we want to do that. So I've already put feelers out there, and Nicole said, yeah, whenever you're ready, if you're ready, you know, we can schedule that meeting with my medical director and we can talk about whatever you want. So I'm working on things in the back end to make sure that what we do is well received within the community writ large, or the healthcare community writ large. I will pass it over to someone else now.
Committee Member Wickenhagen.
Yeah, representing 130,000 nurses in the state, we've been very progressive in regards to MOUD. And as a provider myself, I can't speak for my whole profession, but that's my role. I would say, you know, notification would be probably what the standard would be for my profession. Again, understanding we want to remove barriers, but also be aware of, you know, the progress of their care and could follow up on the backside. Because again, that's nearly impossible when you're seeing 40 patients a day to return a phone call to a pharmacist. No offense. And then I would also say, with previous experience, you know, back to the birth control work that we did here, we did try to, we attempted to notify the PCP, but it was not a barrier to prescribing in the moment.
Just Committee Member Sellers, I think this is a great discussion. And I also, again, a bit of a time check. It's 12:22 right now. So I think once we finish up this topic, do folks want to take a lunch break? Like, how long is the next one going to take before we keep going?
Executive Director, and I personally, if I have any input that's more 2 cents, I wouldn't mind a lunch break. It may give us time to kind of work forward as well. Not that I will require you to work on lunch break, but I will to carry some of the things that have been discussed forward to perhaps make the remainder of what we have to cover a little more efficient. I wouldn't mind a lunch break.
Committee Member Gibler, you have your hand up. And I know there's a lot of information coming at us here, so I really want to hear what you have to say.
Yeah, I just want to respond to my concern, and I feel like based off of everybody's feedback, that my concern has been largely alleviated. I come from I have a long history of building trust with providers over many years as a pharmacist. And I now, in my current role at OHA, I have a broad universal look at everybody and their decisions and the politics behind things. And so I think overall with Director Runyon's comment that he's working collaboratively with other boards and having his feelers out with what kind of reaction people could have with this protocol, especially if we're not notifying them ahead of time. I agree, notifying them after the fact would be appropriate and good, and we do that with other protocols, that I would be fine with proceeding with what everyone has suggested. I just don't want this protocol to get burned to the ground in another year. That's all.
Committee Member Sellers, I totally agree with you, Committee Member Gibler, and I definitely want this to be successful. So is the proposal to strike, or maybe not strike question 11, but inquire about a prescriber, or do we just add in a step at the end for pharmacists and as part of that prescribing checklist to, you know, fax the prescriber and let them know about the new Butte prescription?
Executive Director, and I think the easiest way, or a potential easy way to do that, would be to use this box. We could change it to green, strike out do not prescribe, and say something like notify patient's provider, or however you want to qualify that, and continue. And you could even say notify patient's provider via, document, whatever. And we could refer to the specific thing that we could either require, or you could just leave it as is if you don't feel like requiring, the use of a particular template. If a phone call is okay. But I would suggest that notify patient's prescriber and, continue.
Would it be just to continue to 8 and then when issuing a prescription, notify, because they need to issue the prescription first, and then they'll notify the provider after they issue. So they could do the continue to do it and make sure they notify after prescribing or something, right? So it doesn't limit it. Okay.
So is it yes, continue to?
So they don't have to stop in the moment, because I'm a pharmacist. I'm going to take things literally. If you tell me to stop and fax the doctor, I'm going to stop and fax the doctor and not continue to the next number, right? So like it would just be clear to go ahead and continue to flow and when prescribing or after prescribing using the notification. We can fix the language at lunch.
So continue to 8 and then putting what, not amending this box, putting it at the bottom?
No, it will stay there.
Okay. And just something similar like this.
Sure.
Okay.
Please fix for me.
Yes. Okay. Back to you, Chair Steller. Does that sound agreeable to everyone with consensus?
This is committee member Sellers. Yeah, that works for me. Does that work for others on the committee?
I mean, patience is possessive, so you need an apostrophe, but other than that.
All right, committee member Virgin, are you okay with that?
Committee member Virgin, yes, and I noticed the apostrophe, but yes.
But you didn't say anything. I did.
I did not. I knew you would.
I don't know, maybe I'm on the
Oh,
spectrum
man.
somewhere.
Wow.
Rachel, do we all have to say yes?
We just need one more. So Wickenhagen, Anderson, Hammond agree with that?
Committee member Wickenhagen, yes.
All right.
As committee member Anderson, I also agree.
Oh, sorry, go ahead.
Can I say something real quick?
Mhm.
I might have to jump off the meeting, and so I would just request. I love the spirit of how the approach to number 7 went. I would really like if we could address the same spirit to the infectious disease section as well. If we could go take a look at that again at later after lunch and everything. If I'm not able to make it back to the meeting in time, I really like how this is sort of like being addressed here, eliminating the hard stop.
Yeah.
Okay.
All right, perfect. Committee member Sellers here. I propose that we break for lunch and resume at 1 p.m.
See you all at 1 p.m. Thank
All right.
you.
Thanks, everyone.
say problematic particles.
Want it to end. All right, committee chair Sellers, can you hear me okay? I'm just having to unmute people and just a moment.
Yes, I can hear you okay.
Committee member Anderson, can you hear me okay? And Gibbler.
I'm here. I can hear you.
Hammond.
Yep, I can hear you.
Or oh, and Dr. Virgin, give me just a second. Dr. Virgin, is everything working properly for you as well?
It is.
Okay, super. All right. All right. I believe Executive Director Runyon is going to have me pull up the patient intake form and review a couple of things that we amended or corrected over the lunch break. So committee chair Sellers, does that sound like an okay plan? We just jump back into that.
Yes, that sounds perfect. Thank you.
Okay. I'll just start at the top and
Yeah, just go.
let me share some.
Use other highlight. Okay, Executive Director Running, we'll try to breeze through these. So we included the note up top. We are going to modify the language about continued use despite causing personal problems. Wordsmith that, and we have this other color that I can't really see. I'm red green colorblind, but we'll fix all that. So yeah, we'll wordsmith that maybe a little more per the committee's direction, and we'll just keep scrolling down. like we took out question 3 completely. The reason you took opioids, keep scrolling down. And it looks like we took out all of the mental health questions as well.
Yeah, we did that before the break. I think what we're looking for are items in teal blue, I think is what Bree amended.
And she may have done most of those on the other one.
Yeah, so I don't believe there's anything else on this document. I'll just leave it open though, in case we need to come back, and unless the committee members have questions to it, I'm going to move back to the lovely red and green document.
I would just, this committee member Gibler, on the very top note, we include these symptoms, just wordsmith that so it doesn't say we include these symptoms, because that was how it was written when it was underneath the symptoms that we were asking. So just say we ask about symptoms or something to that effect.
Very good. I'll make that blue so I can come back to that. Thank you.
Okay.
Committee
So
member
committee member
Virgin.
Virgin, we're going to come back to the blue.
Oh, this was just a note for me to work on this offline, unless you wanted to wordsmith this right now.
No, the other blue one on this document
right.
just needed some wordsmithing. Having difficulty fulfilling major responsibilities because of opioid use. You've got like too many parentheses, maintaining employment, or I would just say maintaining employment or staying in school.
Executive Director, yeah, I'm sorry, maybe I wasn't clear on that. That's an internal note to wordsmith it after this. That was just kind of brainstorming between us.
All right. Clean that up. Any other comments on the teal blue edits?
This is Dr. Virgin's just attempt to make sure that committee member Gibler doesn't feel like he's the only one on the spectrum.
I appreciate that. We're all on the spectrum somewhere.
Okay, so here's the induction therapy assessment treatment care pathway. Just scroll down for the
Are you looking for yellow or teal on this one, Bree?
I think just the teal, right?
I don't know if you did teal on this.
So the only quick changes, sorry, I have to run and do something else. If you could scroll down, the only changes were on a little bit further. So we made sure for 7 and 8 to clarify, put it in green, even though it's not the same color. So you could clearly see that it's not a hard halt. It's go ahead and prescribe and with the condition to notify the provider for number 7. And for number 8, to refer to the ED. So you can still prescribe, but if they're having other conditions, to make sure you notify them. I don't know if we got majority on the ED language, but I know that committee member Gibler had put that out before, so maybe it'd be a good time to pause and make sure that the committee agrees with those changes.
Committee member Virgin agrees.
Committee member Sellers agrees.
This committee member Anderson, I also agree.
Committee member Wickenhagen, I'm a little bit in between urgent care and ED, but for the sake of making things keep moving along, I'll say ED is fine.
Thank you.
Yeah. Executive Director, and can we spell out emergency department so they don't email me?
So, staff member Melvin, Sarah, I went back and looked at our other stuff, and they all say refer to ER. So,
And I get it. I get it.
Yeah,
Right.
I just know
unfortunately,
they're going to be there.
yeah, ED means many things. Okay, so are we ready to go to the next then right here?
Yeah, I think so. So, Emily, this might be another great point for you to hop in on the SALS assessment and whether or not we're going to use a hard cutoff on that, or whether it could just be a yes, continue to, and just notify the patient that they may not, that they may get additional side effects if they start too early. Not sure how we want to handle that, but based on the previous discussion, it looks like it should be a yes and instead of a hard halt.
I don't see that's me on the call.
Gotcha.
That looks like you have me Stringfield and the other two.
Or Smee Stringfield, if you want to answer that as well. Even based off Dr. Englander's comments, these are subjective in nature. I mean, it's in the name of the scale itself. And even in instances where precipitated withdrawal occurs, she said that the individual is fine. So maybe it's a yes and we just include that in the information that we're going to counsel the patient on. We could even put it in the auxiliary directions and the prescription itself.
This is Committee Member Anderson. I'm wondering if we could get some feedback from the SMEs about, like in terms of where to start with the buprenorphine, and if depending on the SALS assessment, is there utility in knowing that at that point?
Looks like Smee Stringfield is frozen. He's leaving the meeting and he's coming back, it looks like.
Executive Director Rennie, it looks like he was frozen for a moment, so he may be signing out and coming back in. Executive Director, and I do agree with contemplating whether or not this is either necessary or beneficial or helpful at all. If again they're referring to the fact that the patient oftentimes knows when they're in moderate withdrawal and can make that decision on their own, as long as it's not something that the pharmacist would have to make, then is there a utility in having this at all? Whether we include some sort of cutoff point or patient consultation point or not.
Right, so we may be without any SMEs then.
Oh, no. This
Um,
is Committee Member Anderson again. I mean, I'm kind of looking, yeah, exactly where you have. In terms of like, because SALS is based off of withdrawal symptoms, right? And like we talked about, if somebody is already taking opioids and comes into the pharmacist with saying, like saying that they were on opioids, then they wouldn't be in withdrawal, and then this would end up being a moot point. I guess I'm curious, like, it just doesn't feel like we need this because we're already asking them to start the Suboxone after they're in moderate withdrawal, regardless. So I don't know. Maybe we could somehow work into like the referral to the ER about like just really bad symptoms needing to be referred, but doesn't mean you can't prescribe.
Executive Director running that, and I think in some instances, if the worse the withdrawal symptoms, the more indication we have that starting therapy would immediately be beneficial. So even in that instance, it might be all the more reason to justify starting therapy. But yeah, I agree. If we're telling patients, if we scroll, staff member Melvin, can you scroll a little further down? If we're, again, telling patients all the way at the bottom, I think it's by 13, right there, a little further down. Yeah, if we're telling patients in the auxiliary directions to take one tablet when you're in moderate withdrawal. So they're initiating therapy at that point. We're putting on, the onus on them to make that determination. And is the SOUS really necessary at all?
This committee member Anderson, I think Aaron is back in the meeting, but he can't talk. So would it be possible to unmute him and see if he has a thought on the SOUS and taking that out as a stopping point?
You bet. There you go. Aaron, can you hear us okay? Can you come off mute?
Can you hear me?
Yes.
All right, great. Yeah, would you mind repeating the question? I heard that you were taking a look at the SOUS part of the protocol.
Yeah, so the question is in the pathway with regard to the SOUS and potentially, I'm guessing the reason we asked for withdrawal symptoms, that section says that if their SOUS assessment is really high, 11 or greater, to not prescribe and to refer to another provider. And I guess my argument was that what if they're already on opioids and they're not in withdrawal? And maybe even if they are, like, maybe they need to start it sooner. I guess I'm trying to figure out like why we need to ask for SOUS questions.
So I'm looking at the decision tree. Are you looking at number, is it 12, clinical opioid withdrawal, or the SOUS scale?
It's the
where
SOUS scale. I can't remember in the questionnaire where they ask it. I think it's at the bottom. It's got a
well, I guess,
section.
yeah.
Section 4 is the SOUS assessment.
Let's score 11 or greater. Yeah, I guess yeah, maybe remind me exactly why we would not prescribe if their SOUS assessment score was 11 or greater.
Oh, I'm also seeing Emily back. Is it possible to unmute Emily and see her thoughts too?
All right,
I'm back
Emily.
now? Sorry.
Yes, back.
Okay, I missed a little bit of the beginning of it. Can you just summarize the ask real quick? Is it that do we need the SOUS or what to do with the SOUS?
Yes.
Yes, this committee member Sellers. The question is, do we even need to put that in the assessment? Because will that impact our decision to prescribe, or should it?
I mean, I think it's a nice way maybe to do some education with the patients. Like, these are some withdrawal symptoms. Do I think you need to have a COW score of 11 to do it? I mean, no. I really truly believe that those few objective withdrawal symptoms, and then just simply asking the patient, are you in bad enough withdrawal where you feel like you need to use to feel okay again, means so much more than any score, a SOUS or a COWS. And if we don't need any scale, like a hard scale, I feel like many institutions don't want to get away from that, and they want that to like, I don't know, say they evaluated the patient. I think it's absolutely okay to remove it and not have that part of the decision tree and say, you have to have at least 3 of these symptoms or 2 of these symptoms to start buprenorphine.
So this committee member Gibbler is suggesting that in the prescription itself, we discuss timing of when to start buprenorphine based off of symptoms.
I like that idea personally, and that's how we have our tradition or high dose start in our Harbor Clinic, or when we send them home from the ED, is that we have just this pre-formed, dot phrase that says, here's your symptoms when you have more than these 2, and it's been at least 12 hours after your last opiate use, you can start 1 to 2 tablets, whatever you feel like is appropriate. Sometimes it's hard to fit all of that in a prescription. The restrictions on the prescription bottle doesn't allow us to list out every single, symptom that they would have. But I think it should accompany somehow, like in the counseling or patient handout that's required to go to the patient. Yeah, I can put it. Are we able to put things in the chat? Copy. I have.
We are not, because it's a
Okay.
public meeting and it creates a record. We don't use chat in this group. Thank you.
Okay. I can direct you guys to Scholar Northwest. They have a really good patient facing handout that I'd love to be able to adapt at some point. But it's pretty clear with good visuals to guide the patient on when to start it.
Emily, question for you. Does the
This-
presence, oh, sorry. Are you able to hear me? This is Smee Stringfield. Does the presence of active like fentanyl use, methadone, how would that potentially change this?
Yeah, so with fentanyl, we will generally say minimum of 12 hours after their last fentanyl use, ideally as close to 24 as possible. And then, you know, with methadone, it's a little bit trickier, certainly with methadone, and ideally it's closer to 48 or 72 hours after the last methadone dose. That being said, if someone was on a homeopathic methadone dose, like 30 or 40, I don't have them wait. So there's a little bit of nuance there, but I think that if we have to have some hard limits, we can say at least 12 hours after your last fentanyl use, ideally 24, and at least 48 hours after your last methadone dose. And the other short acting ones I don't care as much about in many ways.
I'm thinking from the perspective of an outpatient pharmacist, they're gonna want a time cutoff, I'm assuming. Yeah. And so for most short acting opioids, would you just give like a 12-hour or less?
Yeah, 12-hour or less, certainly for short acting opiates. I mean, if we wanted to make it just one size fits all, we can say 24 hours after last opiate use.
I like the inclusion of your comments about, or if you're feeling symptoms XYZ, experiencing XYZ for like a patient who's got a take-home script as well to consider.
Executive Director Runyon. Emily, is this one of the handouts that you're referring to that you like to be able to adapt? Okay.
Yes, this is it.
Okay. And I think one of the options that we might have is in number 13 on the treatment care pathway is going in and saying under that auxiliary information, either including additional information about all of those symptoms or creating a mandatory patient handout that would include this and some information about the SALS, but posited in such a way that reflects your intent of saying, hey, if you have 3 or more of any of these, that's when you start, and it would essentially refer back to this to constitute moderate withdrawal. Just a couple of options there, not sure how we want to proceed, but might be a way to satisfy both of those.
We could also, instead of the SALs where they have to rate it, we could just say, the table could list all of these symptoms and say you have to have, put a checkbox if you're experiencing any of these. And one of them, 1 or 2 should really be the objective signs. So the goosebumps, the runny nose, the pupils. The pharmacist can look at that. I mean, the goosebumps and the pupils are the 2 things that are very specific to opiate withdrawal and not like alcohol, benzo, any other symptom, sepsis, endocarditis. You're not going to get those 2 symptoms with opiate withdrawal. And so sometimes maybe highlighting, starring, you have to have at least 2 of these symptoms and 3 or more.
Executive Director, and so would we be able to include this at the bottom of the protocol then, and just have it be like a detach and give the patient sort of thing if we appropriately reference it underneath the.
Yeah, my suggestion, Steph and Baratroff, would be that if you want to create like, the cover letter sheet, that it would be another, instead of a resource, you would put it up in the mandatory handout information. You can have it as its handout embedded there and then reference it in the protocol, like, to be able to pull it out, and then it's easily achieved.
I mean, that's what I said, appropriately referenced, or can we get permission?
Yeah.
Yeah.
And then you're suggesting then on the questions, you'd get rid of the SAL terminology. You just change the question and ask them to check the box on the patient self-assessment, right? Or are we not going
We
far?
may not need that at all
Okay.
then. Yeah.
And this is committee member Sellers. You guys are not sharing the document right now. Just FYI, you're sharing the handout. Don't know if you were intending to share the document.
Just let me know when we're ready to go back.
Oh, I wasn't sure if we were. Yeah.
Yeah, we are sharing.
can go.
Yeah. Smee Stringfield, did you have a comment?
No, sorry, I do have my hand raised. My camera view is all like whitewashed, and so I can't even tell that my hand's raised. I will put it down though.
You do. There you go.
I put it down.
Oh, sorry, wrong form. Look on there.
You got it there.
Sharing it.
Committee member Sellers. So to summarize, we are getting rid of the actual SOWS assessment and listing out potential symptoms. Is that correct? And then saying if you have one or two of them, is that the SME's recommendation? Or do you want the two ones that are really specific to opioid withdrawal?
I would love it if there was a star that had, the three of them that are objective, and then you have to have at least two of those and three or more of I guess, and then at least one other symptom. I'm trying to think about how to. So we have goose flesh, pupils, runny nose. They won't be taking their heart rate, so we won't be able to include that. So maybe they have to have at least two of those and one additional, plus one additional of the other ones.
Isoterm.
Where is it?
It's running nose. Executive Director and Emily, would you mind to go over those, the ones that need an asterisk, just to make sure we got those?
Yes. Do we have the, I guess, the pupil size would be hard because the pharmacist would have to evaluate that.
And this is like a objective. Yeah.
Yeah.
I mean, if they're sweating, is that an objective sign? Yawning.
I mean, it could be due to something else though, right? And not necessarily opiate withdrawal. And so I think that the point of the objective ones is that that's really getting to opiate. That's very specific to opiate withdrawal and not overlapping with like methamphetamine withdrawal or,
I mean, if your nose is running though, I mean that you could have a cold.
True.
There's a lot of overlap with a lot of them, I think. It looks like.
It looks like committee member Anderson and Gibbler both have their hands raised. Committee member Anderson, did you have a comment or question?
Yeah, my comment is I really liked that thing that was pulled up on the internet, but it has more to do with starting the prescription. And if that's the case, I'm not quite sure why we would need any of the SOWs in the questionnaire itself. I really like the idea of making it a mandatory patient handout along with the prescription and having that be what we use instead.
So Committee Member Anderson, you're proposing just striking SOWS and the symptoms altogether and just including it as part of like the mandated patient education handout?
Yeah, that's my thought.
Committee Member Gibler?
Committee Member Gibler, so you're suggesting that we go through this process of assessment and prescribing regardless of presence of withdrawal symptoms, whether they have them, yes, or whether they do not have them, no. We're going to start, and then at that point is based off of timing with regard to some symptoms that are hopefully validated in the evidence somewhere. Because I don't feel comfortable assessing withdrawal symptoms now in the assessment period using a non-validated approach. If we're going to do that, that's all my concern is. And I'm fine with what Committee Member Anderson is suggesting, because that rules out any assessment of symptoms at all currently, but we're still treating based off of timing of symptoms and letting the patient know what those symptoms are, which of course many of them probably know already, but we still have to cover ourselves.
Yeah, this is Committee Member Anderson. I mean, at the very least, even if we do decide to keep the SOWS for not quite sure exactly what reason, the handout, I really like keeping that because of the fact that the prescription itself does say don't start this until you have at least moderate withdrawal symptoms. So I like having something along those lines so that patients know what that means.
This is Smee Stringfield. It sounds like if I'm putting myself in the pharmacist, shoes, that we essentially would utilize like the SOWS or a similar scale to just essentially just go through what those opioid withdrawal symptoms look like, educate the patient, give them an example of what moderate withdrawal would potentially look like, and then leave it up to the patient who confirms that they understand that to apply that knowledge with the buprenorphine prescription that we send them home with. Is that kind of what you're suggesting?
Yes, I think so.
Yeah, that's what I'm hearing too.
Okay.
And I'm in agreement, as Committee Member Gibler, of that handout. I like that handout and how easy it is to read and understand it for a patient.
Committee Member Sellers, I'm also in agreement. I think it's really slick and it's going to be easy for pharmacists to walk through and counsel folks and let the patient make their own, decision on when that moderate withdrawal really is based on those symptoms.
And I wonder if you include a sort of patient acknowledges understanding or, sort of component to this work through.
Yeah, I think educating the patient on what the symptoms are is important, and that could be added if that's not already in the handout.
Committee Member Sellers, on the patient intake form, they have to sign for it, right? That they understand all of that. I guess that's on the intake form though, not after the education, so.
Executive Director Running. So just to clarify, get rid of this. It seems like education to some extent is inherent to that form because it describes what symptoms constitute moderate withdrawal. And we can include direction to give that in the prescription itself, which we laid out. So I guess the only question I have is now the only assessment that we're doing is ensuring that the patients answered, I guess, question 1 correctly, that they do have symptoms of opioid use disorder, right? Is that the only thing that we're evaluating now or assessing now if we're taking all of that away, just for clarification? So the symptoms of the disorder itself, not necessarily withdrawal symptoms, obviously, but.
This committee member Anderson, I would, yes, that's what I'm seeing too.
And I think it's this committee member Gibler, the statute is, I think it's clear that the patient has to have opioid use disorder before we treat. So we have to have that very clear in the intake form.
Second moment to scroll down, scroll to 15. Oh, sorry, on the treatment paragraph.
Oh,
So just for clarification, Staff Member Aframath, the committee is okay with us striking those and then doing the other work to embed what Executive Director Reichman has just shared, that it will be required to provide the handout and give that information related to symptom and when to start taking the prescription. Is that where we're at? Okay, because we won't be
Committee
able to
member
do it
Sellers, yes.
Cool.
okay.
So don't stress, Rach. We don't have to do it at this moment.
All right, let
And
me
this
go
is
back.
this is Smee Stringfield. Does that I can't remember if the handout did mention anything about decision points based off of the patient being on fentanyl or methadone or short-acting opioids or long-acting. No, it doesn't say anything about that.
It does not, no.
One other thing staff will do is we will double check to make sure that this isn't copyrighted in any way that we can't utilize it. I'm just assuming that we can. Most likely, if there's any issues, we will bring it back to the committee, but hopefully it's fine for us to go ahead and use and create as part of our protocol. Just the legal stuff.
Executive Director, and just off of Smee Stringfield's point, if we came to a decision about
Do we
Oh,
lose
I think you
him?
cut out there. We can't hear you. Folks in the boardroom, we cannot hear you. Maybe the next statute should have money for a revamp of their internet service.
I second that.
It's probably that whole building. There's a lot of different state departments in that building.
There are. Have you been there?
Yeah, when I need a new computer, I go there to get
Okay.
updates, new monitors, new computer equipment.
Nice.
I have to figure out where I go from there. I always know where the board at pharmacy is, but that's not where I need to go.
Mm-hmm. All right, it looks like they're coming back online. So this committee member Sellers, it sounds like we're ready with that protocol with the revisions, and we can move on to the next one. Is that true? Committee? Because this is the induction protocol. There's a continuation protocol.
I just want
Chair
to make
Sellers, can you guys hear us okay?
there
Sorry.
we go.
We
Lost our
can,
network.
yes.
Okay.
Now we can.
All right. So, just so I'm clear, we're striking this. Do we need to look at the rest of this document? Or is the committee saying you're ready to open the next protocol?
That was the question I was just asking.
Oh, gotcha. Okay. So I'm not sure if there's anything else you need to present on this, Gary.
I guess the only question I had as we were getting cut off is if there needed to be any minimum window between the last opioid dose and initiation of therapy. We would need to obviously agree on that first, and then I could put it in the comment down there. But I'm not sure if there's a utility in that. Not up to the SMEs, but
This is Smee Stringfield. Emily, what do you think about language being if fentanyl or methadone, considerations for at least time frame of waiting this long after last use, rather than a hard and fast? Or what is your take on that?
I mean, I think that is fine to do. Some patients will not need to wait the full 24 hours or not be able to wait the full 24 hours. So I do like softening up to be considered. I would also be very happy if we want to incorporate that into our guidance document. I'm happy to make a handout that we've developed and we can endorse if that's possible. I'm not even sure. Through the Board of Pharmacy that is, very similar to Scholar Northwest, but we have consider 24 hours after fentanyl, consider closer to 48 hours after methadone, and have that be a decision tree or decision point as well. I think that's very reasonable to do, and I'd be happy to mock something up to send you guys if that's possible.
I would think outpatient pharmacists would be a lot more, I don't know, that would help ease some anxiety about some of those decisions.
Committee member Sellers, I agree. I think that would be great to include.
Executive Director Rennie, I don't know how many further comment on this pathway. So if we want to move to the continuation of therapy, we can.
Committee member Sellers, I am okay with that. Does anybody else have any last burning questions or comments on the induction pathway?
I might have missed this conversation, but do we determine if the initial dose is going to be 8 or 16 milligrams? There was 2 different ones in that document. One said take 1 tablet, one said take 1 to 2 tablets initially.
I just thought take 1, but I don't see where it says 2.
Oh, did I?
Not that I'm opposed to it. I mean, I think
that also warrants some good discussion as well. I honestly think that just from a patient standpoint, the people that precipitated on 4 and 8 milligrams, I think that those 2 are potentially the most risky doses that we can offer to patients to start, because it's enough to feel it, but not enough to feel better from it. And so I would love to maybe have a discussion or to consider having the initial starting dose being 16. There's a few people that I would not want 16 to be the starting dose, and that's, if they're just using prescription opiates and, or using fentanyl once a week, something like that. I also do think that the harm of undertreating and precipitating someone is in my mind, I think, worse than offering someone too much bupe, right? If they have too much bupe in their system, they'll be sedated. You don't get a lot of respiratory depression from it. It has that ceiling effect, so people don't stop breathing from taking too much buprenorphine. You just get pretty sedated. And so I would love to get everyone's thoughts on what would be, if we have to have one protocol fits all, what's the best starting dose to start people out on?
This is me, Stringfield. Emily, what do you think about, I feel like the patients who have been most sensitive to buprenorphine, in my experience, tend to be multiple medical comorbidities, elderly patients, more medically frail. Those are the ones I would have a little hesitancy as far as starting them on 16. I mean, a lot of those patients can tolerate it, but the ones I've seen that are super sensitive, I feel like kind of fit that mold.
I mean, that would all be reasons that I would consider reducing the dose initially as well. But if we don't have, we just have to pick one. I wonder what's the safer, I mean, it's really hard to say this is the safest dose for everyone, but I think that's what we have to do here. I just
Okay,
worry
so
about the very high risk of precipitating with 8
Mm.
in people who use fentanyl chronically.
Even if they are able to take another dose within an hour?
You precipitate, precipitation happens within 30 minutes, and it's pretty bad. And we have upfront conversations with our patients before, say, if you precipitate, it feels very counterintuitive to take more buprenorphine because, if you were to give me a medication that made me feel bad, to get me to take more of it, especially without a healthcare provider saying you need to take this, I think it would be very challenging to do. And so I think what happens a lot of times is people just return to use. And so if we wanted to do 8 milligrams, then maybe we say 8 milligrams, and then in 30 minutes, you can take another 8 milligrams. And so instead of Q1 hour, it's Q 30 minutes.
Executive Director Readiness, is there an option to take 1.5 and 12?
Yeah.
Have no
Committee
input
member
on
Sellers,
what to
though,
do after
that's
that.
kind of annoying. I mean, I don't know, like 1.5 seems.
I mean, we can't be nuanced. We just have to have it's a protocol, so it has to be black and white for pharmacists to use it, and very clear. And the risk has to be very, very, very small, picking the wrong dose. Either way, if we pick the 8, the risk has to be small. That nothing bad's going to happen within an hour, or 30 minutes if we want to change the sig, and vice versa. If it's 16, there's nothing bad's going to happen if. It can be a guarantee, but it has to be kind of bulletproof. That's the problem with protocols, and every protocol we have right now already available. And there's some nuance here that I appreciate, but we just need something written in black and white for the pharmacists.
This is committee member Sellers. So it sounds like, I mean, what I'm hearing the SME say is that for a majority of patients, that 16 milligrams is going to be the way to go. I would be in favor of that. I agree that I think like if 4 to 8 is the ones that kind of get people into precipitated withdrawal, and then they're unlikely to continue, that would be a bad scenario, right? But the other option, if we want to kind of get around it, I also would be fine with the proposal of 8 and then 8 in another 30 minutes, I mean,
I think 8 and 8:30 minutes would be maybe the less risky if we're worried about overdoing it in certain patient populations. And then in 30 minutes, they would, if they were to precipitate, it would be 30 minutes after. And so then they take more, and hopefully.
To me, that's an easier, more straightforward way to go about it versus otherwise we have to list every situation, every patient that would only get 8 in the protocol.
Do you consider an age cutoff possibly, like 55 and older, just to be conservative? You go with the 8 and 8. Under that, 16. Fentanyl, 16.
I mean, there has to be some evidence behind those cutoffs.
There's not. I think if we're going to use any cutoffs, it should be reported baseline use and not necessarily age. And I have a 70-year-old on my servers right now, and he's up to 32. I mean, he's got 32 milligrams.
7. Whoa.
Yeah. So, and I think there's more data and like clinically, you can rationalize baseline opiate use in determining what your tolerance is, right? We all know opiate tolerance is something that I think most of us would feel comfortable, and there's evidence behind it. And so I think that would be better to determine the two, like the 8 versus 16 than age cutoff necessarily.
I think we took those questions out of the intake form that would determine that, didn't we?
No,
The
I thought
prior
that there was.
use-
I thought that there was a prior use at the very beginning. Where it
Okay.
has you listed out. Yeah. And then this is committee member sellers and SME, Emily. You and I actually sit on a committee as well. I don't know, from between OHSU and Providence, and one of the roles is trying to get a kind of a unified protocol that can be used in emergency departments with the intention that folks go home directly from there. And I believe that protocol is landing on 16 milligrams. Is that correct? Yeah. I don't know if that's. I realize an ED has a lot more sort of, people and resources there than a community pharmacy does. But it still is an order set that isn't going to have any sort of downward dose adjustment recommendations. I'm just wondering if there is any sort of benefit from a consistency standpoint of having a similar regimen, or if it just doesn't matter. It's okay if it doesn't matter. I'm just. Mostly it's a question for Emily.
I mean, I think it's a really hard question to know the right thing to do. And the reason why 16 was chosen for all the ED is that there's data for an ED specific patient population. That's the most commonly used dose. For initial, what we call high dose and not the standard anymore, there's a big range anywhere between 8 to 24 milligrams is the starting dose, the average being 16. And so that's where most of the data lies, is with 16. That being said, that data, the biggest body of evidence is in the ED patient population. There's a growing body of evidence in the ambulatory care space, including one but it's case studies. There's case series where the ED is retrospective and prospective. So that's where, it's hard to say one size fits all, but most order sets for this dosing pathway include 16 with some guidance at the top saying if you're using less than a gram of fentanyl a day and you're over 65 or a few other, whatever the institution wants, then your initial starting dose would be 8. But in the ED, the providers can change it.
That's true.
And it sounds like in here, we don't have that
We really
luxury to
can't.
change
So
it.
then if we can't, but I think the spirit of it is to probably allow for 16 milligrams within a 30-minute period, if that's what the patient ends up needing. So I would argue for 1 tablet, and then 30 minutes later, another 8 milligram tablet. I think that does sound like how we're kind of going to meet all of the needs, or as close as we can. Executive Director Runyon, do you have your hand up?
Oh, it's staff member Melvin. Just for the record, committee member Hammond had to leave the meeting. So that's all.
Do we still have enough committee members to
have a quorum? Yes,
quorum?
We're fine.
Okay.
Yep.
Okay.
Thank you.
And this is SME Stringfield. I'm assuming that we do have instructions or education pertaining to patients, how to navigate sedation, over sedation. should that occur.
Executive Director Running, we don't have anything prescribed or associated or incorporated with this protocol, no.
There's also nothing you can do. You find a safe space to sleep and wait for it to metabolize off, unless you want to give them Narcan, which would not be a reason if you're just too sedated. I don't think would be a reason to give naloxone.
I think that's a counseling point that we're discussing that should be part of the process, but not part of the protocol.
I would also just like to point out for the record too, is that if we elect to do the 8 milligrams in 30 minutes, another 8 milligrams, we will not be able to use the Scala Northwest handout because they have a different dosing strategy. So we would have to come up with our own anyways.
Is the Scala Northwest dosing, is that one specific to the emergency room, or is that a take home?
It's a buprenorphine start at home.
Huh.
That website has a lot of very cool resources, and I like it way better than California Bridge. If you guys don't know about it,
Scala,
for Bupe.
yeah.
Mm-hmm.
I mean,
It's
if that's what they're using and they're doing 16, I don't know if I have opposition to going with 16 then. If that's a take-home document that's got some good, evidence behind it.
Executive Director, and so one thing I'll just interject and say, and I know this is going to be a very unpopular opinion, but I want to make the right decisions, not just decisions to, get this done. And I'm just looking at the time. I'm looking at us wavering on, do we have enough data for the spectrum of the patients that we're likely to see to make the right decision? And where's that data come from? Is it applicable, et cetera? Is this something that we may need to work together to craft and then bring back to the committee in another meeting in between now and the board meeting? I think it's February 10th or 11th, 12th, 13th. There are a lot of hoops to jump through for that, I understand. And if you may shoot it down, that's fine too. I'm just thinking broader scale. I want to do what's right for the patients. I want to do what's right for us in the profession. I want to do what's right in terms of, the eyes of the other sister boards. So it's just something I'll throw out there depending on how you all feel about it. It just seems like this point is highly contentious and we have several more to come that we haven't even touched on yet, just depending on your availability.
As Committee Member Gibler, I completely agree with that. I think it'd be nice to come back once we have some of the details ironed out based off of whether something is evidence-based or standard of practice in different communities. I just would feel more comfortable if I knew what I was voting on in terms of some of the dosing, and I think that should be just solidified a bit more.
This is Committee Member Sellers. I agree. I think it'd be easier to push this through if we get another go at it, not just another, look through and yeah, and a solid recommendation on the dosing for sure.
Executive Director Runyon, I do apologize. I just want to say I appreciate staff member Melvin, and she unfortunately would have to do the majority of this work, which she always does without fail, and I appreciate that. And I would just like to ask staff member Melvin, what would be the ideal window given our other obligations with board mailings, meetings, deadlines, public meeting notice, et cetera? So if the committee does continue to agree to reach a quorum on rescheduling, then we can go ahead and perhaps nail down the meeting date or time within a finite window.
Okay, staff member Melvin. So next Thursday, we have a special board meeting, rulemaking hearing. And we are meeting with board president to for him to approve the February board meeting agenda. So then just keep that in your mind as I'm looking at this. So if it could be next week, our office is closed on Monday. If you all are available, 19th would not work. 22nd would not work.
23rd.
23rd of spring.
We are slated to notice the February board meeting on the 28th, and then we would need time to compile the mailings to get whatever comes out of this group ready for the board meeting. And then revised agenda, if that happens for February board meeting, is due on February 6th. So we could not meet on the 6th. We need at least a day to turn the docs around. Does that help?
Yeah.
Okay.
Sorry, what are the options? Heard
So
what we couldn't do. I couldn't hear what we could do. Maybe it's just me.
So if we're looking at next week, the holiday, we cannot do it on Monday. And we probably are not able to do this on Thursday, the 22nd, due to the here.
21st, 22nd, and 23rd, I think are all booked. This room is
booked. You have, there's, yeah.
What about the 26th through the 30th?
That's what I was looking at for.
Yeah.
Like the 29th or the 30th would probably be the most.
So again, if we're taking these to the board meeting, we're noticing the board meeting on the 28th. So if we could do this before the 28th.
We'll change the notice.
Yeah, I don't think so.
We
Just
will
change the mailing.
It will.
I also,
yeah.
as we're thinking about this, want to be mindful too of our fabulous SMEs who have given us so much wonderful input and time. What would we need time-wise for you to be able to have these conversations with us and help us kind of hammer these out and then be able to give you enough time to have thoughtful input with your schedules and when you can meet? Can we just maybe, if you don't mind, sharing your thoughts, Emily and Aaron, or SMEs, what you think?
I'm willing to do any and everything that we all need to feel okay. So let me, I can move things around on my schedule. I can also see if Bradley or Nora can come to another meeting or, weigh in on this specific question. Bradley and Beth are both practitioners in our Harbor or low barrier buprenorphine clinic, and so they're prescribing buprenorphine all the time. So it might be nice if you guys think it would be helpful that I could get one of them to come to the meeting and they could weigh in on it too. Or if you have an email generated, they can give thoughts to it. But I need all of my time or any resources that I have, I'm very willing to pull.
I would say that don't base the meeting off of when I'm available. I feel comfortable funneling information through Emily, who is more available and could be at the meeting, and I would feel comfortable with definitely doing that. But I would love to join if I could. January 29th and 30th, I'm open if we're thinking about in the next couple weeks, but don't let that be a barrier.
Okay, so committee members, staff member Melvin, it looks like based on everything that we can see on staff side, it seems like January 26th or 27th is the ideal time on our end. So committee members, is that feasible for your schedule?
Committee member
Committee member
Sellers.
Virgin, it's not for me.
Okay, it's okay. We'll just take, if we can hear from everyone, that way I can figure out if we have a quorum.
Committee member Sellers, that works for me.
Okay.
Could you repeat those dates?
January 26th or 27th, with just how it aligns with our board meeting would be ideal.
Yeah, that I can make that work.
I can try to make that work. I will need to check. But I most likely can.
Okay. Committee member Wickenhagen, how about you?
Yes, that would be preferred actually for me. Either the 26th or the 27th. End of the week is not possible.
Okay, and then I can reach out to committee member Hammond. So with 4, that's our quorum, right? So that could work. So what is the suggestion for today? Are we thinking adjourn and then just bring back the rest of the mailings to the next meeting? Executive Director Onion?
That would be my preference.
Just thinking too, Stefan Rachmaninoff, I know it's important to have all voices heard and from different backgrounds too. And I think it's Dr. Virgin who's not able to make the next meeting, and just trying to keep into consideration too, if we do have the ability that if we can send updated documents and get feedback to, I know sometimes when we mail them out, you guys provide us feedback ahead of time of what your thoughts are, which are super helpful for us to be able to make edits and such forth. So if there is that opportunity to do that for Dr. Version too, I think that might be a good idea too. Even though you can't make the meeting, we can at least maybe hear some of your input as needed related to, we can bring forth to the group or make edits to the document too, just so we can try, or anyone else that's not able to make it, even though we still have a quorum, trying to get everyone's voices heard.
This is committee member Virgin. That would be acceptable, and I could do that.
Thank you.
Okay, so with that, if the committee agrees, then this would be a great time to motion to, or entertain a motion to adjourn. Committee Sellers, Becky.
Yeah, committee member Sellers. Did anyone sign up for public comment?
They did not. I'm sorry, I forgot to mention that earlier. So we do not have any today.
All right. Is there a motion to move to adjourn the meeting at 2:05 p.m.?
Committee member Gibler, so moved.
Is there a
Committee
second?
member Virgin, seconds.
Excellent. We'll do a roll call vote. Committee member Anderson.
Approved.
Committee member Gibler.
Yes.
Committee member Hammond had to step off. Committee member Sellers says yes. Committee member Virgin.
Approved.
Committee member Wickenhagen.
Approved.
All right, this motion passes. We will adjourn for the day, and we will reconvene that either Monday or Tuesday, hopefully at the end of January, and go over maybe some more finalized elements of this protocol as well as the next protocol.
Thank you, everyone. We appreciate it.
Thank you all so much.
Thanks, everyone.
And Smeeze, thank you.
Bye.
You're amazing.
Appreciate it.
This is great.